Welcome to the Remarkable Dentist Podcast with me, Fred Joyal, where I interview amazing dental practice owners digging into their successes and failures, their insights and hindsights, getting their views on where dentistry is going, and discovering what it took for them to become remarkable. Welcome to the Remarkable Dentist Podcast. I'm Fred Joyal, and I'm here today with none other than the CEO and founder of Pacific Dental Services, Steve Thorne. Steve, welcome to the episode.
Hey, thanks, Fred. It's great to be here.
Yeah, so for those people who have lived under some sort of dental rock for a long time, give us the rundown on Pacific Dental. I know it's one of the largest DSOs, dental service organizations in the country. Give us the length and breadth of Pacific.
I'll give you the Reader's Digest version. So yes, I know this is about dentists, and I am not a dentist. I don't think you're a dentist, are you?
No, but I have an honorary doctorate, so I will make people call me doctor sometimes.
I have an honorary doctorate also, so it's Dr. Joyal and Dr. Thorne, but I come from a family of dentists, and I got out of UCLA in 1989, bad year to go out into the business world. My dad was a practicing dentist and asked me to come computerize his dental office. And in 1989, those of you that remember those days or were alive during those days, computers were a new thing, and especially in a dental office. And I was pretty good at it, helped him get it started, learn the ins and outs of how to bill and all the electronics and all the stuff. So helped him out a couple of years, helped him grow a few practices. And I go, hey, there's a real business here. All these dentists, all these friends of my dad wanted my help because they saw him booming. They go, can you help me? And I go, there's a real business here. I got to figure this thing out. And so I did. Started Pacific Dental Services in 1994 with Dr. Carolyn Gazal, who's still with me today and still charging hard.
Wow.
And we are now up. I don't keep track of how many offices. We probably have about 850 practices in 100, and I heard we're in like 127 DMAs now. I don't really look at the states. That's not. It's more like the metropolitan areas that's important to me. We have about 3,000 clinicians in the organization, and I think on size, if that's what matters, we're probably number 3. To my big competitors, Bob Fontaine and Rick Workman just did some acquisitions recently and surpassed me.
Well, because you don't acquire. We'll get into that, right?
Yeah, we don't acquire. We only open.
Just as an aside, I just noticed something as you tell your story. Imtiaz Manji, who has done dental consulting forever and started Spear Institute in Scottsdale. Right. He started exactly the same way as you, helping dentists computerize. And so it's an amazing similar story. He went a different way, but you and I had, we started in '86. We were barely computerized. There were no hard drives on the computers when we started. So, it would be
my dad. I don't know if you know this, but you may remember my dad was one of your first customers up in the high desert of California, way back when. I think in '89 he was one of your customers.
Yeah, they probably came on. That's when we really spread out past the LA metro area. Right. And so let's get right into your business model. Is I would say not atypical, because I think there's several ways to go, and actually probably dozens, if not hundreds of ways to create group practices and dental services organizations. But and some of them are they buy practices and manage them. Some of them do buy practices or start practices, create what we call de novo practices, and some of them just build from scratch. And some of them are branded like Aspen Dental, and some of them, like you, are not necessarily branded. So all these things are interesting factors, interesting because they all work.
Dentistry's in you and I have been at this a long time. You a couple of years longer than me, but it is a great time to be in dentistry. I mean, I think hopefully you'd agree with that. It's probably the best time in my 33 years. And
I
so,
mean,
yeah, they're working. The different models are working.
yeah.
I'm fond of our model, and obviously I like our model because we stick with it. We tell dentists, look, you can be in business for yourself, but not by yourself, and you're supported by a very large organization that has a lot of skill and a lot of systems in place to help you be super successful in owning your own practice. So we have a true owner doc model at every location. We're not branded. It's a local name and a local doc that practices there. Local docs. We run larger practices. So that's our model. Yeah.
Yeah, and also important to note for doctors who are listening, it is not branded as the dentist. It is branded as the community, essentially, the neighborhood.
Correct. Very locally branded. And there's a reason for that. Dentistry is still very local. Most patients go to their local dental office. And so we've stuck with that strategy we played around with a couple different things in the early years for sure to try to figure it out. But we've been just laser focused for probably 2 decades on that strategy.
Okay, so what's the dumbest thing you've done along the way?
Oh my gosh, we're gonna be here for hours. So okay, so from growing a business, if there's an audience out there that really wants to grow in this space, under investing in technology when we were at hyper growth speed was painful. And you've got to match. And I'm speaking from a CEO's perspective. I've done a lot of other dumb things, but you've got to match your investment in the operations side with the investment in your infrastructure. And more, you actually probably need to be ahead on the infrastructure and your IT and all that spend and your security and all of that ahead of your growth, because it's just everything runs through IT. As we say in our company, everything goes through legal and IT. Those 2 departments, you got to have nails. So I learned that the hard way, but we've spent 5 years investing in our infrastructure now, and I'd hold our infrastructure up against anybody out there at this point.
Well, and I remember many years ago sitting down with you, and we were just talking because we were both, in Los Angeles and in the industry, and you were showing me, and this had to be in the 90s. You were showing me all of the tracking that you did even then, which had to be much harder than it is now because there wasn't a lot of broadband into the practices.
Right.
But you kind of knew even then what every practitioner produced every hour, if I'm not mistaken.
Every minute. Oh yeah. Yeah. We measure. If it can be measured in dentistry, we measure it. Now, it may not be top of mind because we have certain metrics we look at, but if it can be measured, we measure it. What gets looked at gets done. And so we want to make sure that we're bringing the most important data points to our organization, to the practicing clinicians out there, so they can make good decisions on their time allocations and how they're doing.
So you'll typically set up a practice. How many operatories? You're going to do demographic research on where you want to plop the next practice, I assume.
Oh yeah, we do.
Being a numbers guy, you're looking at it 16 ways before you decide.
I am a data guy and a numbers guy for sure. I play the odds. A lot of people call me the Moneyball guy because I'm the data and want to play the odds and help get the odds in the favor of the team that's performing out there in the field. So yeah, we have a robust choice. Now, we're not perfect. We've had some mistakes in the real estate choices, but we spend a lot of time looking at where practice should go. And The smallest practice we'll build is roughly nine operatories. And, we'll build it. We have practices, 30, 40 operatories. So,
wow.
Yeah.
And so that a lot of it is what the traffic will bear, and physically, literally what the traffic will bear in the area. But that's, and so there's generally, are there always specialists in the office as well?
Oh yeah. Yeah, we're full specialties. About half our revenue is specialties, half GP. I believe we're probably the largest multi-specialty group in the world. I know Aspen just brought Clear Choice, so they have a big group there in that world. Outside of that, we're probably the largest multi-specialty. So we're really good at that referral process back and forth between whether it's a pediatric doc or a periodontist, oral surgeon, endodontist, and all of that. So.
And yet, you talked a little bit about investing in technology.
Right.
You were one of the first practices that really leapt onto CAD/CAM technology.
Right. We were.
And
so a couple things there that I remember working with you on. We actually worked on a program together, I think way back when. I think it was in the early 2000s, you and I on some CEREC stuff in CAD/CAM, right? But we were the first large group to go to digital X-rays. So we went from film to digital X-rays in the 90s. I think we were the first large group to go to an electronic health record, rather than the dual entry system that existed when we grew up in the space. And then we moved over to CAD/CAM dentistry because, if a patient could come in once and get their crown delivered in under 2 hours, which is generally what we can do, I think that's an incredible service to patients. And so we try to teach all clinicians to be very patient-centric, right? And think of the patient first and how we value their time and value their money, and really put the patient at the center. And so it just made sense.
Yeah, I call it speed to exit. Because
that's a good one.
They love this. They like to say, "Oh, my patients love me," and I'd say, "Yeah, they want to love you from afar, though." That's right. They want in and out as quick as possible, and they don't want to be bounced to a specialist and then have to come back. They don't want to zigzag around town to complete treatment. It's one of the craziest things that a lot of dentistry still does. And so that's why multi-specialty works so well.
It does. And think of that crown as an example. So it's one of the most common procedures for general dentists, right? Doing a crown and kind of their bread and butter. And if they do it the old school way, they prep it and they do an impression, and then they have to send that impression out to a lab. They have to temporize that crown. Hopefully that temp doesn't fall off, which some do. And they have to wait for that crown to come back. And when that crown comes back, the patient also has to come back. So they have to get in their car, drive there, get seated. So you go through 2 sets of PPE to seat that patient. And then hopefully that crown does fit, and they cement the crown and send the patient on their way. So in my mind, you did at least 2 times the amount of work, sometimes 3 or 4 times the amount of work for the same procedure.
And there's, of course, the fact that you're not getting paid for anything but the first procedure. So if you have to cut that temp off, if it doesn't just pop off, or they didn't already knock it off, you're numbing the patient again, drilling the patient to get that temp off, cleaning the whole tooth up, and hoping, and we know this, and I'm sure you know the number to 2 decimal places, what lab crowns don't fit on the first try, right? Yeah. So if it doesn't fit with a CEREC or some other CAD/CAM device, you make another one.
Yeah, we know when we were doing our research on it, we knew exactly what percent and what percent of temporaries fall off. We knew exactly our remake percent. And I can tell you that those have improved dramatically since the implementation of CEREC.
Yeah,
sure.
and those numbers are indicators of a non-patient centric experience. Coming back, and oh, it doesn't fit, we have to do it again, kind of thing. Or you have to. How many dentists are grinding down the perfectly ceramic crown that they had to put on because the fit is not exactly right?
Yeah.
So where's that ceramic finish? It's gone. So patient doesn't really know that, but I know that. I know what happened. So you've basically been an early adopter on tech because the numbers dictated it. Because you started that way, looking at what was costing you time and therefore money and therefore patient satisfaction, and you went network wide, I guess you would call it.
Yeah, for sure. So I'm very methodical. I don't look at ourselves as necessarily a technology forward company. We look at it very good at implementing proven technologies. We had our first CEREC machine in 1994, to give you an example, the old CEREC 1, and it'd been around a long time, right?
Yeah.
I mean, we didn't start implementing CEREC till the mid 2000s on any sort of scale. So proven technologies are super important in dentistry, because you can get, and especially now, there is new tech coming at us every single day, and you can get whipsawed. And a lot of it they become great dust collectors in the side of an office. You've seen them. And so you've got to be smart about technologies. An example right now, we're converting the whole organization from what I call 2D to 3D. So 2D x-rays have been around since you and I have been in the space, but 3D now is where it's at. But cone beams have been around for what, 20 years, maybe even longer. I don't know. I know we had our first cone beam, I think in 1998, if I remember right. So that's longer, that's 23 years. So yet, what's happened is the technology is now there to take these big images, because they're big images, and
gigantic.
then they're gigantic, and then move them around to the operatory so the dentist can actually use the images and talk to the patient for patient education. We can store those images, so those images are compressed and pushed up to the cloud, where we can store the images and keep them safe, and keep them from all HIPAA compliant, anonymize these images, and then use them now to apply assisted intelligence to them. So it starts getting super exciting when you think about kind of where we're at in dentistry. I like to say we're moving dentistry from tooth technicians now to oral healthcare providers, even call it primary care providers in the whole primary care world.
Yeah, I'm just thinking about if you've got roughly 800 practices, just for round numbers, and you're doing 2,000 cone beam scans a year, you've got 1.6 million separate dentition with the data associated with whatever's going on in that mouth. That's a staggering amount of valuable data that once the AI goes in and starts looking around, can be incredibly revealing. And it is software driven. It's like, how do you get that incredibly complex amount of data into something you can show the patient? And I tell dentists all the time, I say, you want to impress people, show them a rotating 3D image of their soft and hard tissue. They've never seen anything like it. And why wouldn't you want that data on every patient?
Ours is more like, rather than 2,000 a year, it's 2,000 a day. 2,000 a day that we do that with. And it is super powerful to explain all that to patients, show them the bone loss. I mean, in a 2D x-ray, I don't know what the exact numbers are. I'm not a clinician or a scientist, But I've heard that you can't see the bone loss in a 2D x-ray till like 30, 40% bone loss. So the disease has taken place, damage has happened, and yet the radiographs don't show it.
Yeah.
In a 3D, you can see it all the way down. I've heard as low as maybe 5% or so.
I've
and
watched it
these
happen
patients.
where they slide the mouse over the image, and it's changing the percentage of the bone density
Right.
on every bit of the image. I mean,
Right.
it's what a phenomenal piece of information, especially if you're explaining to the person who's missing a tooth or 3 or 5 or an arch, and you say, this is what you're losing, no matter how good a denture I make you. Right. So
right.
this is why, if you want to be eating and preserving the way your face even looks,
right,
this is what's happening, and it's only going in one direction unless we stop it.
Right. So. Right. And it's a great tool to build trust with the providers, right? So many dentists, my experience is almost all dentists do an incredible job. They try really, really hard. Great people try really hard. Yet there is a skepticism in the public about dentists and dentistry because they just don't know. Yeah. They can say they show them a 2D x-ray and they think the patient understands, but they don't. They don't. Or it doesn't hurt, right? And so, and then the dentist says you need a crown or you need a root canal, but it doesn't hurt. Doesn't hurt, doc. I'll wait. Well, now with 3D, it's one of those areas you can show them. And there's all sorts of new stuff coming out around more what I call predictive and preventive care. And so it's a super exciting time. We can now test the oral bacteria in patients' mouths, and we know which bacteria are either causal or make people highly susceptible to other chronic inflammatory diseases. Because ultimately, right, periodontal disease is chronic inflammatory disease.
Yeah.
And so when we can help lessen that chronic inflammatory disease, we can lessen the inflammatory response in the rest of the body. So whether it's cardiovascular disease, Alzheimer's, or diabetes, or
the list goes on and
the list goes on. Yeah.
And because most illnesses are related directly to inflammatory disease in the body, or just inflammation period in the body. And I don't know if you've been able to generate the numbers about this, but what I've seen, what I think happened in COVID, is this opportunity to connect overall health and oral health. It did like a jump in the where you could equate it in the patient's mind. You say, one of the reasons why some people are getting COVID and others aren't is some people's bodies are fighting infection all the time, starting in their mouth.
Right.
And I think they can get it. Whereas before it was like, my mouth is not related to my body. My health insurance company already told me this. Right. So.
Right. No, it definitely was a catalyst to speeding it up. My take is that it was already happening, although slowly. Yeah, it was happening. Surgeon General report in 2000 at the time, he said, look, we can't have good overall health in the United States without good oral health. That kind of got the ball rolling, and the Surgeon General reports ever since have been pushing oral health. And so you've seen, and you've probably seen all the studies out there. There's a great study released recently from the New York Medicaid study, 518,000 people. If this study doesn't cement the deal, I don't know what does. 518,000 people, age I think like 45 to 64 years old, because at 60, in this country, once you're 65, you're not eligible for dental benefits anymore, which I think is one of the craziest things in the world. Before that, you do get them. Right when you need them most, you don't get them. But anyway, we'll see if that changes. So they looked at these patients, and then they did a super simple study. The study was done by, I think, Ira Lamster at NYU or at Columbia. And they looked at the number of cleanings they got over a 2-year period. Then they looked at their cost of healthcare in the 3rd year. So super basic study, okay? So whether they got 0 cleanings, 1 cleaning, 2 cleanings, 3 cleanings, or 4 cleanings. And it was directly inversely proportional to their cost of healthcare the following year, just for getting good cleanings. The studies are showing that if you're consistent in your oral healthcare, that's where you get the most savings.
I mean, that's a fabulous study, and it's big. It's large enough, but it's, as you say, it's connecting two very simple dots so that you could say there is causation here. This is not conjecture, and this is not your dentist saying, "Oh, you need to come in 3 times," and it's not one.
Right.
And it's a great way to lend credibility. I love it.
The skeptics will tell us that, well, it's not causal. They may have changed their behavior. And my answer to that is all 518,000. Yeah. And my answer to that is, okay, do we care? Do we care? If we're true healthcare professionals and we helped them get healthier, stay out, do we care whether it's perfectly causal or not? We shouldn't care. It's definitely highly correlated. I don't think you can argue that it's not highly correlated. I'm with you though. I say it's causal.
Yeah. So let's jump and talk about the generations of dentists that you've experienced. Have you noticed shifts in who's coming out of dental school versus who you were hiring 20, 25 years ago?
Yeah,
that's a gender change. Obviously, that's a huge.
Yeah, massive gender change, right? 53% of people in dental schools right now are females, and so we have a massive number of females in our organization now, and they're awesome. There was a big worry, right, 10, 15 years ago that females were going to get into dental school and not practice full time. I can tell you, my experience is not that at all. They're out working just as hard, if not harder, than the men out there. So I have no qualms about the availability of dentists for the future of America. But no, these kids coming out, they're smart. They are smart, and they want to do well. They want to be healthcare providers. They do. They want to. They're not just about the money. And the beautiful thing about dentistry is the better you get at providing overall healthcare for your patients, the more money you actually make. And so it's awesome. But no, they're smart as a tack. They want to learn how to do implants. They want to learn about all this stuff around what we call mouth-body connection. They want to learn about more about periodontal disease. As you know, they changed the AAP guidelines in 2017, which is awesome. They want to learn more about implant retained dentures if a patient can't get an all-on-4. Just they're awesome kids. I call them kids now because they're the same age as my kids.
I know, because you're having the same experience as me. As we say, oh, we started my business in 86 or 89, and they go, yeah, I wasn't born then.
Exactly.
It's like, fine, good for you. But one of the things when they talk about Gen Z and the younger millennials is impact is way more important to them. That their lives are making some sort of contribution, and of course, as we know, dentists get to do so much positive for people on almost a daily basis that it's like an embarrassment of riches, I call it. Like I tell dentists, it's like, you're so used to doing something like this every day, you don't realize that some people go their whole careers and don't change anybody's life or don't make anybody's life that much better. I want to talk to you about something personal, because I learned something this year about you that I did not know, or I learned it really last year, is you adopted your kids.
I adopted 3 kids, yes. I have 7 children.
Oh, okay.
4 grandkids, adopted 3 of them.
So you have, I'm confused on it. You have 7 kids that.
I have 7 kids, 3 of them are adopted. One is from California. All 3 are black. One is from California. We adopted him at birth. And 2 are from Ethiopia.
Oh, wow.
So yeah, it's really cool. And so we've been doing a lot of work in Ethiopia over the last 12 years because of my kind of my affiliation with the country, both in our partnership with Charity Water and building we helped create the third dental school in Ethiopia. Ethiopia is one of the most populated countries in Africa, 115 million, 120,000, 120 million people. At the time we started over there, I believe they only had 2 dental schools. So we helped start the third one in a town, in an area called Tigray, in a city called Mekelle. The sad thing is that Tigray is in a civil war right now with Ethiopia. So we haven't been able to go back there. And it's a pretty nasty civil war that's been going on for 5 or 6 months now.
Yeah, I mean that is tragic, and so one of the things that you commented on is you were not aware as your kids were growing up what their experience really was being African American.
Right.
Yeah, which is to me is interesting just because you are their dad, but at the same time they're not going to come back and go, this is what I'm hearing, Dad.
Well, we're open about it. We have to be open about it when we go out in public. People notice, right?
Right.
And you still get people that will my wife was telling me just the other day with my 17-year-old daughter, they're in the grocery store and somebody turned to my wife, one of the helpers there, asked if they could help my wife with something. And she said, no, we're all good. And then she turned to my daughter and said, can I help you with something? People don't connect the dots still.
Right. Yeah. It's not going to be assumed. Now, are the Ethiopian kids just gigantically tall? I mean,
no. Actually the opposite. Well, it's interesting. One, my daughter's real short, actually, and my son is starting to bloom up. So we'll see where he ends up. We never got to meet his dad. We did get to meet his mom, and when we're going there, we'd see her mom every time we go. So we've seen his birth mom 7 or 8 times probably, and she's only on a good day she's 4'10". So you'd think he'd be really small, but he's now approaching 5'10", so that tells me his dad must have been huge.
Yeah, he was compensating genes in there somewhere. So,
yes.
Well, I mean that's an amazing thing that you've done, and certainly great to have you as a dad and just so open to giving them a life in the U.S. So I admire that. I contemplated adopting back when I was married, and it never happened, but right. I could have seen myself doing it. So.
Yeah, it's not for everyone. It's not for the faint of heart, and God blessed us obviously with great business, good money, so we can afford to do it, get the education they need and all that. But I encourage people to adopt, but I also talk to them about having their eyes wide open about adoption, and because they're not your genes, and they're going to do stuff, and you go, where did that come from? And right. You can't point at your spouse, like you could with your biological kids. Yeah. That's your side.
You got that from your mother. You don't get to say that. Right?
You don't get to say that. So it's, but it's great. We are tight as can be, and it's awesome.
Okay, so getting back to the industry, let's talk a little bit about the trajectory of the dental insurance industry. We've watched it go in all sorts of directions, and mostly not for the better. I mean, certainly right. From its origins, right? Because its origins were to help people to afford dentistry, and it was formed by dentists. When people ask me what I think about dental insurance companies, I say, this is the bastard child that came back to kill daddy, basically, because I don't have, there's nothing they can do to me, the insurance company, so I can be incredibly frank about it.
Right. Well, you can get me on my soapbox on this one. It's interesting when you think about the dental insurance industry. So You and I have been doing this over 30 years. The basic dental plan hasn't changed in those 30 years. And I call them dental plans, right? Back then, a $1,500 max covers some services. Maybe they're up to $2,000 max here or there, but we had $2,000 max plans in 1989 also.
Yeah.
And so the basic plans haven't changed. And I don't call them insurance, although it's the common name out there, because they're truly not insurance, right? They buy a network or rent a network, ask that network to take a discounted fee and put a cap on the amount they'd spend for that. And then in exchange, they send you patients. So in that respect, dentists, at least what I try to teach our dentists, we're grateful. We're grateful they're out marketing, getting people engaged in oral health and getting them to their practice. So we are grateful for all the work they do in getting patients signed up on these plans. I would like to see it evolve. It's incredibly cumbersome. I heard a data point today that the average practice spends 7% of their costs. I don't know if this is accurate. I know I can tell you some numbers for us in a minute, but 7% of their costs to work with carriers, get paid with carriers, do the credentialing and blah, 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 which sounds about right. I know we employ about 1,000 people that work all day long on either eligibility, credentialing, or trying to get paid. The basic system of how you bill and how they deny and the paper you have to send and the x-rays you have to send and the images and all that hasn't changed. There's just so much friction in the dental plan industry right now that has to change. If we want to improve oral health care in America, if we want to get more people in the pot, more people coming to the dental offices and have rising tides for all of us, we have got to solve this problem once and for all around the friction in the dental plan space and dental insurance industry. There's so much unneeded friction, and we've got to somehow work together to change it.
Yeah, and the friction is beneficial to them, but the cost is it's ever increasing in terms of, as you say, the fact that some employee time is going to that, and it's not productive, and it's not productive, satisfying work, to be sure.
It's not helping the industry either, right? Patients get upset about it. Patients don't like all that friction and getting a denial from a insurance company. And to your point, both sides are incurring the costs. I'm not really picking sides here. I'm just trying to point out a something that needs to be solved, right? The carriers have all their costs to administrate all that also, but so do the groups. And so we're doubling up on costs. If we would work together to solve some of these things, I think we could eliminate a massive amount of cost and friction out of the system and spend those dollars to engage, get more people going to the dentist. Because what, only 40 or 50% of the American population goes to the dentist every year? Let's get 60 or 70%. We'll all be better.
And the impact on overall health costs based on that study, right? If we're one of the highest percentages of our GDP in the world is spent on healthcare, imagine if you could impact that by a point. Right?
Could you imagine?
1 percentage point of our GDP would be a staggering amount of money. And it probably could be 5 points if you could just get people to go to the dentist. Why wouldn't that, that preventative care have a phenomenal impact?
The impact's more than a point too, Fred. I think we both know that. I think I read a study, I think it was by United Healthcare. Don't hold me to this number. I do have a copy. I can send it to you. But I think the number was like 3 or 4% in their own study. 3 or 4%. I mean, man. Yeah, and I know it can be more than that.
Yeah. So that's almost a baseline number as a percentage of the gross domestic product of the country that could be reduced in healthcare. It also means people aren't sick, by the way, right. Or dying, with heart disease being the #1 cause of death in this country. let's see if we could take that down a little bit.
Well, I think we have to think about the coding system too. This has been a big topic of mine the last few years as I'm out speaking. You know, dentistry, as far as I know, is the only healthcare profession in the United States that has its own coding system, right? We have a CDT coding system, so we don't work on we don't work off of the ICD-10 or ICD-11 or whatever it is. If we could do that, right? If we could get in with overall healthcare, the claims data that's available with the diagnostic coding and some of the things, we can prove out those cost savings in such a powerful way. And employers, I believe, I employ 15,000 people. If they told me I could save 4% of my overall healthcare expense for my population, you think I'd say, yeah, heck yeah.
Yeah.
And I think we can get there.
Yeah, I mean, there's companies that understand that, and and I certainly understood it. As all of my employees we had health and dental for them. Starbucks spends more on healthcare than they do on beans, and which is interesting. But it's about the service, and also having good employees, which means you take care of your employees.
Right.
Which is keeping them healthy and keeping their teeth healthy. We certainly had people. I had younger people working for me a lot of times who would just never cross their mind to have health insurance. That would be the last thing they'd invest in. And so I said, you're going to have it whether you like it or not, because I don't want you coming to work sick, and I don't want you, breaking your arm or something like that. And you got to figure out how to pay for it, or you're going to county health or whatever, or you're just impacting the whole taxation system in another way. But yeah, anyway, as you say, we could probably dive very, very
we
deep.
Could spend
on this.
hours talking about all this. I think there's some discussions now happening in some of the meetings I'm in about how to solve this problem, and it's I think it's one of the biggest areas to solve for oral health care in America in the coming decade. I think it can be solved, and think of the pharmacy, right? They sort of solved it in that area to a degree. We could pick apart that too. But when you go get your prescription, right? You go in and they already have what your cost is. You pay your copayment, your patient share, and you leave, right? Okay, that's the same transaction we experience in dentistry, yet there's no claim form that goes out, no adjudication that happens at some center in Milwaukee, nothing against Milwaukee, no dentist that denies the prescription and then sends it back to the pharmacist for more information, and no EOB. Maybe you get an explanation of benefit once a month from your care or something. They've solved it.
Yeah.
Why can't we solve it in dentistry?
Well, and that's, as you say, it's like we have two systems working very hard to add friction to the process, or to deal with the friction in the process, in a world where I can order my groceries by saying them to Alexa, right? And they show up. I've touched nothing, right? And this is the way the rest of the world has moved. And yet we're still doing all of this. Oh, well, send me this and send me that and move this and add that. And so, no, that's not right. And it would be easier if you did nothing, right? And just it's like stores who go like, they assume 5% shoplifting. They don't fill the place with security guards, because that would be bad retail, right? So they just go, 5% of the stuff's getting stolen. So what? Right? It's cheaper than security guards.
I don't want people thinking we're going to have 5% fraud in dentistry, but if you ask Deltas, I don't know what the fraud rate is in dentistry. There's going to be some bad apples out there, right? We know that. There are some bad apples. Well, so is it 1%? Do we build that into the system? There's going to be 1%, but hey, you and I both know with computers now and AI working, we can catch fraud probably within minutes nowadays. I would venture to say within minutes.
Yeah, think how fast the credit card company gets a hold of you.
Yep.
It says, "Are you sure about this charge?"
Sure?
And you go,
Right.
I'm not in Prague right now.
Yeah, and I'm not a pro.
So yeah, it's something to be solved. And I think the fact that there are organizations in dentistry that are commercial organizations, not societies, right? Like
Mm-hmm.
you and Bob and Rick and people of size, you can have an impact on this. You can say, look, we represent millions of patients here, and we are trying to figure out how to take care of them and reduce the impact on the whole health system by what we do, simply by making it easier for people to take care of their teeth. It's like this bizarre assumption that people will do way more dentistry if you give them a lot more money. It's like, no, they're only going to do what they need anyway, right? They're not. It's not.
I'm with you.
Not,
it's we still have to collect the patient share. I'm not an advocate for limiting patient share. We still have to pay, and that's the throttle, right? That's you and I both know that's the throttle. So as the patient share goes up, more dentistry will get, less dentistry will get done. So if there's amount that an employer can spend, actuarials could figure that out, right? I think.
Yeah.
It's just not it's like a battleship right now is the problem, or a freighter going in the ocean, and it's really hard to turn it.
Yeah.
I'm not complaining. I'm not complaining. I think there's just something we can all solve.
Yeah. And and we're all working towards it. And as the data comes in, and eventually you get somebody to listen to it, somebody who says, how can we eliminate a really expensive aspect of healthcare? Oh, here's a way that we've known for 10 or 15 years that you might want to apply. But there's got to be some political capital a lot of times associated with it, unfortunately. But then sometimes it's not. Just like Uber solves the weird taxi problem that we've had for so many years. It's just somebody comes along and says, here's a better way. We're just gonna and it implements like crazy because everybody goes, that's way better. Right?
I think we're gonna see something like Uber-like in how dentistry is paid for real soon. I think in the next 12 to 24 months, I'll bet you see something.
Yeah, and so probably because you're deeply involved in it and can't tell me.
There might be some truth to
that. So this has been a terrific conversation. Obviously, there's so much more we could cover, but I'm mindful of people's absorption levels.
Right.
Some parting thoughts that you might have on the industry in general, or to dentists in general, or whatever.
I think we're at a unique moment in dentistry and in oral health care that comes along once or twice in our careers of revolutionary, evolutionary, innovative change that's happening that's huge. So these things are all happening at the same time, so it's a bit confusing. The dental medical integration is happening. The move to 3D, the ability to apply, I think augmented intelligence in 2D. It wouldn't shock me if most dentists within a couple of years have AI there to help them out and use it. It's in schools now. We're seeing other types of technology. The amount of money flowing into oral healthcare to help it elevate its game is unreal right now. And I truly do think it's the best time in my career. I'm really excited, really pumped. I'm an investor still, not a seller. As you probably know, we're privately held. I'm probably the last group of any size that's privately held. So I'm an investor into dentistry, into oral healthcare. I'm an investor into the future of oral healthcare. and it is a great time to get involved, and just get excited about it and start learning. It's an awesome time.
Great. Yeah, I totally agree. And I thank you for your time, Steve. I thank you for your friendship over the years, and love the chance to get to exchange these thoughts. So I wish you continued spectacular success, and look forward to seeing you out in the world sometime soon.
I'm sure we'll see each other at these fall meetings coming up. Thanks, Fred. Great to see you. Take care.
So everyone, Steve Thorne, CEO of Pacific Dental Services, with some fascinating ideas and revelations and insights for us. Please subscribe to the podcast, share it if you like it, and in the meantime, keep on becoming remarkable.